The topic this evening is going to be alignment, Blount's disease, and Rickets. And Mohammed, you're just going to WhatsApp me if you can't hear me. But so really, the thing that maybe just wraps it all together is going to be this concept of alignment. And so I wanted not to get stuck in the detail of normal lower limb alignments, but just quickly refresh us. And I'm going to go through this quite quickly. Pravesh, I suggest that if I'm going too fast, you just, I don't know, phone me or something. So,
okay.
So we're going to quickly just look at, and this is from another talk, but defining normal lower limb alignments, bearing in mind that if we want to simplify it, we're going to try and make a linear representation of limbs, touch on that difference between anatomic and mechanical axis, centered of the joints, define the joint orientation angles, and try and just make sense of the angles that we tend to use, but sometimes get a little bit mixed up about. So just quickly, on the left-hand side, there seems to be a fairly obvious metaphyseal deformity of the distal femurs, both sides. It's obviously Rickets. And at this stage, probably fairly easy to identify where the problem is and how to address it. But if you look at the right-hand side X-ray, obviously there's now a deformity that's occurring in at least two places, proximal and distal tibias. And if we're going to resolve all of this, we're going to have a little bit more in-depth just identification of what we're doing. So just quickly, now really I'm going to rush Pravesh and Mohammed. But your normal alignment, we can take a femur, bearing in mind that the proximal femur is going to be an offset between the center of the axis of rotation of the femoral head and the shaft. So it's not a straight line, obviously. The tibia itself is very close to being a straight line between anatomic and mechanical axis. Now, I'm going to just remind us about that here. Remember that a mechanical axis is a line connecting center joint to center joint. It's always a straight line, whereas an anatomic axis is a mid-diaphyseal line. And in the case of a lateral femur, for example, it may be curved, and it may differ over here from the mechanical axis, particularly in the femurs. So a mechanical femur goes from the center of joints to the middle of the knee, whereas the anatomic axis goes through the center of the femoral shaft itself. And this differs by about 6-7 degrees of valgus at the distal femur. Mechanical and anatomic axis of the tibia should be exactly the same, except that because of the load bearing, your mechanical axis tends to run slightly lateral to the anatomic axis. And then I've pointed this out briefly. Your anatomic axis in the femur is a curved line. In the tibia, the anatomic axis is slightly anterior to the mechanical axis, and this just comes into play if you're nailing a femur. And if you think about it, go backwards. Think about how you nail a tibia. Your entry point is actually anterior to the articular surface. And if you go back to the anatomic axis of a non-trochanteric entry nail, piriformis entry nail, that anatomic axis comes out medial to the greater trochanter. So we join joint center points we determined so that we can determine our mechanical axis. How do we do it? We really take the center either by a circle over here, or we divide, in the case of a plane type joint, we're going to divide the joint in half. Next, we just remember that we look at joint orientation lines. Why would we do such a thing? Well, if there is ligamentous laxity or joint disruption, you might have normal axes of the bones themselves, but within the joints, there might be malalignment. And you'd look at this both in AP and lateral. So your your joint orientation is going to give you a guide of metaphysis versus diaphysis, of your axis versus the joints. And then if you then line up your joint orientation, and I'll get to this later, you will see that at times ligamentous laxity may mask or may be isolated in the context of a deformity. So the outcome of all of these lines is going to be this, a stick figure. And then I had a couple of questions. We're not really going to get too bogged down here. I want to just touch on this here. Where do anatomic and mechanical axes differ the most? Well, it's going to be femur, really, both AP and lateral. Forget about the posterior slopes of the tibia. It's a whole discussion about weight bearing and your rockers in terms of gait analysis. Your joint orientation lines may, and I've alluded to this, may give you a guide both to the joint themselves and to the orientation of the diaphysis. Thanks, Peter. And they're standardized, and we get a little bit confused about the joint orientation lines. Why would you need them? Just have a look at this diagram here. Bear in mind that within the metaphysis, and try and pick up the pen here. No, I can't do it. So if you look at the metaphysis of the distal femur, it's going to be quite difficult to define where there's an abnormality. It's going to be easy enough in the midshaft, but difficult towards the end. And so it's at this point that your joint orientation lines come into play. There's specific nomenclature that attaches to them, and by convention, we go for the smaller. If there are two possibilities, for example, medial and lateral in the distal femur, you would go for the smaller of the two by convention. So I'm going to once again rush through this a little bit. Your frontal plane mechanical and frontal plane anatomic have specific normals, and I'm not once again going to dwell on it. And then very briefly, a joint line convergence is going to look at, and I spoke a little bit about this briefly earlier, about intra-articular congruity. So I'm going to pause there and just have a look at whether there are in fact, and I don't easily see whether you've got questions. So Pravesh, I suggest if there are, just WhatsApp me. Let's get on to Blount's disease. And so Blount's is of interest to us because it's prevalent in South Africa. It's relatively common, and there are actually very few, when you look at it, very few hard and fast answers to the question as to what we should be doing. There might be principles, but the details may be a little bit vague. And so to try and, through the process of this talk, get an approach rather than answer all of the questions. So by definition, it's a growth disorder involving the proximal medial tibial physis. And there are associations, and remember we briefly touched on this last Friday in the meeting, that the associations would be genetic. There are also associations with obesity and a family history. And then there are known associations with those groups of individuals who have an earlier walking age. And so the theory, just to explain this a little, the theory is this, is that most children are born with physiological varus of their knees. If you walk early, that tibial varus that is now inherent may become prolonged. And if so, that may be one of the triggers, along perhaps with obesity, to Blount's. None of these are going to be absolute, but that could be one of the things. The next one is tibial torsion. And if you think about this carefully, if there is internal tibial torsion, then on heel strike, in the gait cycle, when there is maximal force through the entire lower limb, at that point, if you have internal torsion of the tibia, that would lead you to recognize that there would be an increased load on that medial physis. And remember that the Euler-Fulton principle suggests that with increased load or increased force across a physis would be inhibition of growth, leading then to diminished growth. And so that really talks to the concept of increased load on that area. Obviously, as the varus becomes greater and greater, the load itself is going to increase. And that becomes important later when we speak to unloading of the physis as part of a management strategy. So then just for those of us who have to deal with mothers, and remember that probably one of the most difficult aspects of pediatric orthopedics is going to be to deal with the associated family and hangers on that come with the patients. I suspect that most people in adult medicine are enormously relieved by the whole concept of being able to get rid of a family, just get them out of the picture. Whereas for those of us who still have to deal with pediatrics, that family is nonetheless still there. So physiological vera is usually present. I try and explain to the moms that children have to be varus because otherwise they wouldn't fit nappies, but obviously it's nonsense. I also have the nonsense rhyme that says skew by 2 and straight by 8. In fact, the height of angular deformity is closer to 3. But you know what, it keeps everybody happy. And I think in this, the important concept is that reasonably off the age of about 2, physiological varus should be improving. Be a little bit careful here, because sometimes with changes in particularly body fat and with standing and walking, the varus that was previously not visible to the mother, and I've already spoken a little bit about having the mom, that varus might become both better but more prominent in her eyes, or the father for that matter. So just bear in mind that they may say that it's getting worse until the age of 2, and I'll accept that. But after the age of 2, and certainly beyond the age of 3, varus should be improving, not getting worse. And I think, and we're going to talk a little bit about Rickets afterwards, I think varus that is worsening after the age of 3 needs attention. So, a brief classification of Blount from Milwaukee. And that was originally, he described 2 very distinct subsets of pathological tibia vara. The first would be the infantile, and just be careful here because it came up the other day again, and that is just because a child presents at the age of 10 does not make that a late onset Blount. What in fact can have happened is that tibia varus was always present, has been getting worse, but for whatever reason they've only presented at this age, in which case we're going to call that late presenting infantile. And I want to stress this because the radiological picture, the clinical picture, and the course of the disease is going to be different from the late onset, and strategies for it are going to change slightly. The late onset is then also subclassified into a juvenile and adolescent, but I think for the purposes of this right now, let's focus on those 2 groups and then go into the detail later. So how are we going to assess it? And what would normally happen is, hopefully, in the ideal case, there would be an initial consult. Let's say after the child started walking at the age of 1, you would then see them at the age of 2. And at this point, there is varus, and you're trying to work out, you're trying to put in place a filter to say, does this need attention, yes or no? Is this progressive versus physiological? And I think we already alluded to the skew by 2 straight by 8. That is one aspect of it. So after the age of 2, is it getting better? And then are there the other hallmarks of Blounts. So, is the child overweight? Did the child start walking early? Is there already the varus, the torsion that is often part and parcel of this? I'm just trying to get here. And I speak about this, the clinical aspects, the four components to me of Blounts are going to be the varus, obviously. Tibial torsion, and if you look here carefully, this is unilateral, so who is that registrar? I don't notice him outside of the lead there. If you look at the foot progression angle bilaterally is straight ahead. But if you look at the left-hand side, knee with the Blount is the patella should be facing laterally as a mechanism to compensate, to rotate the foot inwards. I think that there is here a lateral thrust, which is just the fact that on heel strike, there is a lateral deviation as that slightly flexed knee allows the tibia, or allows the femur actually to fall into the defect of the posterior medial tibia. And lastly, you don't really see it that well here, but there's going to be a procavatum. Right. So you've got a clinical presentation, and we're just getting back to the fact that hopefully this is an ideal case. Special investigations, x-rays, and ideally, once again, AP mechanical axis standing. This implies patella facing forward. Now, I have now accepted the fact that either one needs to go down every time to radiology and supervise this, because what the radiographers want to have happen is to place the feet forward, because that looks neat and tidy, in which case, however, the patellas are going to be deviating laterally. What you really want is the patella forwards means you have to go downstairs yourself and make sure that the toes are internally rotated by about 30 degrees. You need to line up the patella. And there are a couple of filters now that are radiological, and Drennan describes a metaphyseal diaphyseal angle NDA. His article, more than 12 or more, is going to be significant. And depending on the amount of angulation that you choose would then depend on how sensitive such a screen is. And so there are other authors who have then stated 18. 18 would say that basically everybody who has an MDA of 18 has Blounts. 12 gives you a little bit of leeway. The X-ray appearance in the infantile type now is going to go through 6 stages described by Langenskjöld, ironically from Finland, so I'm not quite sure whether you've got his patients. But nonetheless, I simplify it, and I don't really expect anyone to be able to classify, except if you're going to sit down and do a study, except for this, is that from 1 to 3, there should not be the evidence of physeal bar formation. And from 4 to 6, there is early to established physeal bar formation. And this makes a very big difference, because if you don't have physeal bars, then you can probably get away with some form of unloading of the medial proximal tibia. If you do have a bar, then you need to adjust your strategy appropriately. Quickly, I'm just going back on what I've already said, infantile being early and late presenting. Infantile, the Langenskjöld 4 to 6 presumably usually are going to be late presenting existing tibia vara that is just coming to you later than you would have liked. And as a rough guide, your Langenskjöld staging roughly goes per year equals your Langenskjöld stage. So generally you start forming bar at the age of around about 4. You want to tackle this thing before that. It's a little bit variable, but that's about the age that you want to be. You want to be ahead of that curve. So I've spoken a little bit about this. The concept of physial arrest would occur from 3 onwards. And then we need to spend a little bit of time just talking about whether this is physiological versus Blount. And so once again, if you go backwards in the plain radiology, if there is both femoral and tibial varus, that would imply physiological bone, or for example, the Rickets. Whereas if there is only a tibial deformity, that's strongly suggestive of Blount, and there are papers that compare a ratio of the amount of varus in the tibia versus the femur. And obviously, if it's predominantly tibia, it's going to come out in that, and your ratio is not going to be 1, it's going to be greater, and if so, points towards Blount. If you have progression of your MDA, whether you're measuring it via your 12-degree cutoff or Perishunicus 18 cutoff, if it's getting worse, then it points towards Blount. If it's receding, physiological, and you can probably, at 6-monthly intervals, just think about watching and waiting. And lastly, unilateral generally is going to point towards Blount's disease. Remember that apart from Rickets, and we'll deal with that a little bit later, there are not many conditions that are going to give isolated varus. Isolated valgus, we had one the other day in the clinic, maybe a metaphyseal fracture, which is a transient thing, and we think is overgrowth, but that's a valgus tibia, not a varus one. Very few things that are going to cause varus, and so just watch out for it. We've talked a little bit about evaluation, torsion, Stewart Dix-Peek. Stewart Dix-Peek is just the fact that along with lateral thrust, which is something that happens with gait, Stewart Dix-Peek is the difference between the fully extended knee that generally does not have an increased tendency towards varus, whereas the slightly flexed knee and inflection, it's quite difficult to talk to the sort of empty screen in the camera. But if one flexes the knee to 30, 40 degrees, you would be uncovering or unmasking the inherent, let's call it a hole, that would be the deficiency tibial plateau of Blount. And into that, then your Stewart Dix-Peek, or your tibia, you get the impression that the tibia is falling into that gap. Radiologically, I've talked about the MDA, the Drennan angle versus Perishunicus angle. Then Hoffman, in his article, also wanted to look at, in infantile Blounts, to what degree the medial tibial plateau was deviated from where it should be. Now, once again, there's a little bit of controversy here. Bear in mind that there is an upper downward slope in an infantile proximal tibia. And so that actually, in order to use this angle, one would really need to stratify age, because by the time you get to 20, you should not have a significant difference between the two. But at the age of 3, you would easily have 30 degrees. And for the purposes of a study, he took 30 as the cutoff to signify when would we need to do something. And I would just add to that, and once again, it's a little bit frustrating without being able to show you, but in addition to the medial slope of the proximal tibia is also the shaft that is also in varus. So there are 2 components to this, and they're usually both there. There are occasions in infantile Blounts where only one or other is there, but generally they're both there, and they both need to be treated in turn. So a slide from Muhammad, an algorithm, a concept of how to deal with a problem based on binary treatment protocols. Selma, year-round, not the so the algorithm that we'd like to get with Blounts would be based on a combination of age, the infantile versus late onset, because they're 2 fairly different diseases, and in the infantile, those with and without the medial physeal bar. And so let's just try and dive into it a little bit. And let us assume that in age under 3, where there's both femur and tibia involved, that's resolving, that there's no features of infantile Blounts, that we could probably do repeat x-rays and watch until the age of 4 years. So that's on the left-hand side. In the age, under the age of 3, that's tibia alone, that is progressing, that does have the internal rotation, maybe poker bottom, overweight. Now features, clinical and then radiological features of infantile Blounts, the cupping, beaking, and increased metaphyseal-diaphyseal angles. We would then, given the fact that we have not got a bar, lung and scalp less than 4, for that group, ideally we want to unload the proximal medial tibia. So what are the two potentials? One can do a high tibial osteotomy, an H2O, and the thinking behind that is to mechanically unload the joint to reverse that Hoyte-Fulkman principle and to allow the medial physis to recover. At the same time, there's the added advantage that if there is an osteotomy, the internal torsion, then I think may be part of the problem, can be addressed. But that may not necessarily be the case. I'm quite happy to acknowledge it. The other potential is to do guided growth. And what are we doing here? We would now be creating what's Hoyte-Fulkman effect now laterally, slow down the growth on the outside, allow the inside to catch up and eventually slightly overgrow, throw the axis into slight valgus and keep the medial physis protected. What's the disadvantage? Well, we don't address rotation. And bear this in mind as well, that eventually with physeal growth, there is an ill-defined zone where angulation can be so large in terms of its magnitude that there simply isn't a place for guided growth. Sometimes guided growth is just not powerful enough. The physis remaining may not be able to overcome the forces that it's required to overcome. So that's kind of where we are. Now, what about the lung and scald 4 and plus? It's going to be a gray area. And obviously, it's the gray areas that always interest us in terms of algorithms. It's the outliers that would be exciting. So let's say that you're now lucky enough to have a late presenting on the left-hand side here, late presenting Blounts, 4 to 8, and there's no bar formation. Well, then go backwards and treat it like the under 4-year-old, high tibial osteotomy or guided growth. What about bar formation? And now we really are in a tricky zone, because if you already have a physeal bar and you're thinking about doing some form of correction, you need to be aware that you have got this ongoing tether to medial growth, and that the chance of recurrence is very high unless you complete the epiphysiodesis laterally. If you do that, you're going to restrict growth, and you'll remember that the proximal tibia contributes about 6 millimeters a year to growth. And so if you're 4 to 8, you're in a place that you might be looking at 6+ centimeters of growth remaining, which is going to be significant in terms of eventual adult height. So just think about that. That also needs to be balanced with the fact that sometimes, and I'm saying this is a very gray zone, one might elect to do a high tibial osteotomy, knowing at the time that the problem will recur. It's a conscious decision. And one would explain to the mother that this would be a stopgap measure that and generally that would be reserved for the extremes of tibial varus, where one could simply not just leave the thing, but one wants not to be doing an epiphysiodesis and so one is already planning on a later strategy, or one does the full correction and thinks about a lengthening at the same time as the episiodesis. And bear in mind that in the unilateral case, these decision processes might be slightly different to bilateral. If both legs are affected equally, that may change one's approach a little bit. Bear also in mind that visually, and this shouldn't be the primary goal should be a stable knee joint and correct mechanical alignment. But there's also the consideration about cosmesis. And to have very stubby lower legs might look odd at final outcome if one is elected to choose to do shortening procedures. So put that into the equation. Let's say that one is greater than the age of 8 without physical bar formation. So really this would then raise the question as to, over the age of 8 through 10, is this really infantile? And let's then say that it's not, because that's generally the case. You have presented, you didn't have infantile Blounts, you didn't have junior varum, and this is a new problem. If there is not a bar with potential of physical arrest, then we would agree that the treatment would be a high tibia osteotomy, with the caveat, and that's this, is that look at then the distal femur and try and work out if there is significance in the older patient who is not the infantile type, who then also has a femoral malalignment, because that may need to be addressed in addition. So just bear that in mind. Or one is now older than the age of 8 on the right-hand side with physical bar formation, and this historically is where we used to go. Teddy and myself, we used to try and hold the children to the magical age of 8, and at this stage do a double elevating, well, let's call it a joint correction osteotomy plus a valgus osteotomy, because that's really what it is. So the elevation of the joint would be to realign the neutral axis of the joint itself, and at the same time there would be a proximal tibial osteotomy to correct the varus. And then, importantly, add an episiodesis, and this was one of the major parts of Teddy's article, to prevent the whole thing at the age of 8, remembering that there's still 6 years of growth in a girl and 8 years in a boy, to prevent it recurring. When are we going to address this joint depression? And this is where we get this fairly arbitrary, and I'll try to point that out, number of 30. I think that ideally one wants to end up with a joint that is going to hopefully last for a lifetime. And it sort of makes sense to me that a congruent and neutrally axially aligned joint is going to be the best possible chance of that. So it may be that the numbers are incorrect, but that's what we currently use. So if you have a reasonably aligned medial tibial plateau, high tibial osteotomy is the way to go. Whereas if there is significant joint depression, then think about a joint realignment osteotomy plus an episiodesis plus an alignment of the varus itself. And just to pause there for a moment, because this question came up today, is how does one know where and how to get this alignment together for the proximal tibia? And so my technique, my trick is to rotate the proximal tibia in such a way that one gets, with the image intensifier in a vertical orientation, if you get a single edge-on plane of deformity. At that point then, you know that if you, in addition, also then have an osteotome that is also end-on, that the plane of the osteotome and the plane of the deformity are congruent, they're aligned, and that if you make them cut accordingly, that will elevate in the plane. So you are not mismatching two different planes, which is very easy to do if, for example, you are just in a rotated plane looking at the joint. I was also asked today about arthrograms, and I think they're useful. I think they define clearly where your end point of trying to realign the medial proximal tibia would be. I think they clearly demonstrate, and Stanitsky had a paper to say that there was no room left in the joint. It was all hypertrophied meniscus. That's not the case. You can clearly identify that there's a gap. You can open and close it. You can visualize it on dynamic screening. The disadvantage to me is that the omnipaque, the dye one uses, lasts quite a long time, and it tends to blur later the lines that one is. It becomes a distracting image to look at trying to align the joint surfaces. But there you go. I have used it. I continue to use it. I acquiesced to one of the registrars recently. I think it does help in visualization. You must just be aware that it's going to get in the way a bit later. What about the fact that there is medial bar formation? If there's no medial bar, I don't know where I was going with this. It does remind me of the question about why don't we, like we do in many other instances, for example, post-traumatic, why not just go in and get that bar? Why not cut it out and do fat interposition and or cranioplast and let it recover? And the answer is we've tried. Both Teddy and myself, and in fact Louis Sparks separately, have tried to address physical bars. All of us have failed. We've tried to map them with MRI, and that's been unsuccessful. There's a complexity to the bar and an incompleteness to it. So in a post-traumatic bar, often the actual fascial bridge is fairly easy to define, and it's normally mature. Whereas you can see that from the age of 4 to the age of about 6, 7, there's a progression of both maturation of the fascial bar in Blount's and its spread, and it's quite difficult to determine where exactly to go. And we know that you cannot simply go further than about 30 to 50% of a physis, and certainly to try and remove only 30% of a medial physis, technically it has been difficult enough that none of us have got it right. So I wanted to have a single unifying theory of the whole concept, and in fact there's not really. I think that unfortunately that the principle might be this, is that if there's no bar formation and it is varus and it's infantile, unload that stressed medial physis and watch. If there's already bar formation, try and evaluate how close one is to the end of linear growth, and then either, if there is significant joint depression, elevate the joints and correct the varus, or if there's not significant joint depression, think about realignment and completion of the bar formation. In addition, about femoral osteotomies when there is femoral deformity. But I don't think that there is, particularly in the light of Pete Murray's talks last year at the Congress, probably not as simple an answer to this as we'd like to have believed 10 years ago, 15 years ago. So I'm going to pause here a little bit and just have a look here. And the chats. So there's nothing. Everybody? So let's just break for 3 minutes. stopping the video. I'm stop. You can chat. Muhammad, are you here?
Yes, boss, I'm here. I can hear you.
Questions? Have we covered? Hopefully, have we at least got an approach to where you want it to be earlier?
Yeah, that's clear. Yeah, thanks.
No, it's not clear. It's clear to you. I've got it across from. It's not clear to me, but hopefully an approach is more clear.
Yeah,
Pravesh, you happy?
Yes, boss. Yeah.
Andisha, welcome. Good to see you. Who else is here? Cool. So then, if everyone's happy, we're going to go on then to Rickets. I've got nothing else in the chat. So Rickets is kind of a weird thing. It's interesting to me, and it is coming up more and more. I don't know. Somehow, I think Rickets is becoming interesting to everybody else because vitamin D has now become the new panacea for everything. Everything either has a vitamin D deficiency or has vitamin D as part of its cure. I don't see Steve Roche, but everything from heart disease to cancer is now vitamin D. I'm not doubting any of that. Bear in mind that historically a lot of pediatric, in fact a lot of orthopedics, and remember orthopedics, orthos, straight, pedis is a child, and a lot of it came from axial deformities from Rickets, and the industrial era in Europe generated so much pollution and a lifestyle and living conditions and the diet that eventually created dietary rickets where none existed before. Very interesting, a whole epidemic just caused by becoming wealthy in a funny way. So we no longer actually see the rickets that we would have seen in a Dickensian era. What we do still see rickets. And so just quickly here is rickets. Here is on the left-hand side, the bowed legs. Fairly typical bone. And even there, in my left hand is the swelling, medial swelling of the ankles. The wrists, definitely that distal swelling in the wrists of rickets, that Rickettic rosary. I haven't shown you the frontal bossing. In the dietary type rickets, the child themselves is also stunted and often quite irritable. This child is also stunted, by the way, but this is not a dietary rickets, and we're going to get into what sort it is shortly. I'm just looking. I did not miss anything in the chat. So osteomalacia is a broad term that implies that there is malacia, abnormal softening or wetness, abnormal softening of the bones, and Rickets technically is osteomalacia in childhood. In adulthood, we refer to osteoporosis. Remember the poof that we talk about of your soft bone diseases, the Paget's, adults, H, hyperparathyroidism, and the triple O's, osteogenesis, osteomalacia, is Rickets, and osteoporosis in adults, and then the F for the fibrous dysplasia. You can WhatsApp me if you want that all over again. So in Rickets, clinically, I've talked about this. You get the bossing, Rickettic rosary, enlarged swelling over the joints of the epiphysis, bone, and the delayed or abnormal dentition. The radiological picture of Rickets is osteopenia. And I've said this before, that be careful and just look at this X-ray. Be careful of looking at it at a glance and saying, well, those bones look quite white and hard. Because of the fact that modern X-ray machines are auto-exposing, they would then take into, just like a camera would take into consideration the light, they would take into consideration the bone density and expose accordingly. And so that whereas 20 years ago, we would have a standard X-ray for a child's hand and wrist that would show clearly that this bone is osteopenic. It's difficult here. What I would like it to do rather is to look at the diaphysis of the radius ulnar and just see that there is failure of formation of a normal cortex. And so in a child, that loss of a cortex is a good sign of the osteopenia. In the fascias themselves, you have widening, cupping, the cupped metaphyses, the flared epiphyses, and then the fibrillation. You do see this, I see it on my screen, the speckled appearance of that widened physis itself. So this, in order to distinguish what is the cause of the rickets in front of you, the short answer I've always had is just refer to a pediatrician. I've got interest in these things. But now you guys are coming back from the exams and telling me that you being asked to fill in matrices, or at least have some idea of how it all works. Yarpi says that he's just going to forfeit the points, and he did pass, so there's that approach as well. Big Red and Little Red can tell you in depth all of the differentiations of rickets. So I think that my own personal approach to this is, I work in the field. I would put together the pieces of what now might be needed by a pediatrician. I'd kind of put it together, wrap it up, and then present it to them. I wouldn't necessarily want you to know all of this, but you know what, it comes up. So let's just try and sort our way through this and think about it a little bit. And I just need, and I've got the comment box open so you can jump in, because I seem to remember I got a couple of these slightly wrong, not many of them. So let's start with vitamin 2, vitamin D deficiency, and who's going to get it. And unfortunately now I can't see any wild vegans on the group. But the place that I now, over the last 3-4 years, have seen nutritional rickets has generally been funny diets. The first was a very intelligent, high-end couple with a small child. They had decided that to give even soy milk was going to be harmful, and so they had a completely milk-free diet for the child. It was all a little bit weird, and the child ended up with florid rickets at the age of 8 months. So that was, let's call it semi-intentional, but also a mistaken approach. A couple who arrived in Cape Town middle of winter 2 years ago from Congo, stayed in a flat, had then transitioned to a fairly sensible vegan diet, but hadn't really thought about the child and where vitamin D and calcium are going to come from. And now and again, we do find that there are dietary deficiencies, but generally few and far between. What are we going to look for? Calcium. Remember, and I just need to explain this, is that the hemostasis of the body is programmed to try and keep calcium at a normal level. And the reason is simple. Calcium is part of your neurotransmitter and muscle function, and if it goes haywire, you're going to die, basically. And so think of calcium in the bones as a bank, that just like we are now in the middle of COVID, we are drawing from the bank to try and keep an economy afloat at the expense of long-term financial health, let's face it. The same thing applies in Rickets, that you would be drawing from your bony reserves to keep your serum calcium hemostasis and ignore the fact that your bones long-term might become weaker. So you're going to maintain calcium in dietary Rickets. You're going to lose phosphate. And the reason is this, is that you would excrete phosphate in exchange to trying to retain calcium in the kidneys. Your alk phos is going to go up. You've got increased bone turnover because your parathyroid hormone has gone up. And why is that? Because you are trying to mobilize calcium stores from your bones. Your vitamin D, well, it's down because you have a deficiency, and your 1,25-dihydroxy vitamin D is also down because, well, you've got no substrate to convert to in your organs. So that's kind of makes sense so far. Next, the commonest cause of Rickets that we're going to see is going to be the hypophosphatemic Rickets. And this one's quite nice because in hypophosphatemic Rickets, there's no phosphates. You can't form your bone salts with calcium. Your calcium itself is going to be normal. There's nothing wrong with your calcium. And I really want to drag you across to your parathyroid hormone then, because it's one of the few Rickets where your PTH is going to be normal. So hypophosphatemic, normal calcium, normal PTH. Phosphate obviously is down because it is low. That's what it is. The alk phos is raised because you've got increased turnover of your bone, or it may be in fact normal. Your vitamin D is normal, and your 1-hydroxy vitamin D is also normal. Remember that because hypophosphatemic Rickets is X-linked dominant, your females can be affected. Your mom might have it and her daughter. So it's not like hemophilia, where it's going to be the mom carrier, son is affected with the disease. And so we've got a couple of families where the mom comes in bowed-legged and stunted, and the sons and daughters are similar. Sorry, the mom or dad, we'd have to now go through the genetics. The renal failure. In renal failure, for various reasons, both because your kidneys are leaking calcium, your kidneys are leaking protein, and because your kidneys are failing to metabolize your vitamin D from raw to active forms, your calcium is going to be down. Phosphate, because you're not secreting it actively, is now rising. Your alk phos is being turned over because of your parathyroid hormone, both of which are up. You're trying to maintain calcium hemostasis. Your vitamin D generally, because your dietary vitamin D is normal, is going to be okay, and your 125 may be normal or diminished because down the line you're not converting it. But in general, this is going to be the picture in renal failure. In your hyperparathyroidism, generally primary and generally an adenoma, your PTH is going to be up, therefore your calcium is up. And because you are now secreting your phosphate in order to retain calcium, your phosphate's going down in the kidneys. That's under the action of PTH, parathyroid hormone. Alk phos massively raised because you're just churning over your bones. In fact, you're leaching them out at an incredible rate. PTH obviously is remarkably raised. Vitamin D and hydroxy vitamin D are both going to be normal. You don't need any of it. You've got an out of control regulatory mechanism. And lastly, now I don't think that you're going to get here, but your dependent vitamin D dependent types, these are either going to be the renal defect in processing vitamin D or an end organ resistance to it. And the biochemical picture is fairly similar. Calcium and phosphate down. The only difference is your active metabolite is in your vitamin D dependent type 1 is going to be down, up in type 2. I don't think that particularly matters. I think what matters is that either you do not have the active vitamin D form, where it is down, you haven't metabolized it, or you do have it, but it is not having any effect on the target organ. And so then, here was my summary of the whole thing to try and highlight, and you're welcome to this group of slides. Mohammed, you can share it. In each of your categories, what's going to stand out? Well, vitamin D deficiency is going to be vitamin D. The thing that stands out in hypophosphatemic to me is parathyroid hormone, which is normal. In your renal rickets, your phosphate goes up because your kidneys can't excrete it. In your dependency, your vitamin D is either markedly raised or markedly diminished, either because it's not being converted, or in fact because it has end organ resistance and is being overproduced. So we are at 9 o'clock. That's the end of it. So we can quickly go through questions. Mohammed, questions? Pravesh?
Boss.
Thanks, boss.
Questions? Anybody else? I'm just looking.
Boss.
Yes.
Yeah, just wanted to ask. It was once discussed with one of the colleagues concerning rickets in terms of deformity correction. Is there, in your experience, is there like room for guided growth, or you'd rather consider osteotomies for deformity correction? What's your take on that?
Yeah. So there's a couple of rules here. The first is that they be very, very, very careful of operating on a child with active rickets, because the metabolism of the bone is so drastically altered that you are running a very real risk of non-unions. So just be cautious there. That's step number one. How are you going to work it out? You can look at biochemistry and you can look at your physes, and to me the standard X-ray is going to be the AP left wrist. That by standard is what we look at, both of diagnosis and resolution. So that's step number one, heal the Rickets. Number two is your deformities in general are going to be multi-apical. They're going to occur at different levels. But if you think that you can sort out two deformities by two separate areas of growth realignment, guided growth, I think that there might be a place for it. Just be cautious though, because generally by the time you've got a banana and you are trying to create an arrow, you're going to maybe end up with a double S. I know that I myself have had this experience that you may now create double deformities. It may work. And so long as you're cautious about how you're applying your guided growth, that may well be a reasonable strategy. Also be careful. So just bear that in mind, and I'll get to where I think it would be helpful shortly. Also be careful of the fact that a child with stunted growth, think now hypophosphatemic rickets, that child, because the growth is slower, your correction time is going to be longer. And so you may be running out of time, or you may be taking so long that it's just not reasonable. So if you're only growing at half the rate, you're going to correct twice as slowly. So that's my next point. I do think that if you have aligned aspects, and certainly this happens both in osteogenesis and in rickets, that if you've aligned certain aspects of a deformity and there's tweaking at the end of a long bone, that it's perfectly reasonable Given the fact that you've got a slower rate, if you're going to have growth stunting, you've got a slow rate of correction, I think it's reasonable to be doing such a thing. If that's the sort of long answer to your short question. Anybody else?
Thanks, boss.
Anybody? Any other questions?